liven up a room. So that is where we are. Okay, so switching topics to one of the saddest, every semester it's a toss-up, which is sadder, child abuse or pediatric cancers, as far as subjects that I have the privilege to talk about to you guys. So things that we're going to talk about. There is not a whole lot of oncology on your pants. However, one of the reasons that I particularly harp on it here is you often will see the presentation of pediatric cancer more than I will. So in a peds clinic, a lot of times they're not coming to me. They're worried about something in a background, and so the parents are going to the people that they trust, that they see for their own care, to be like, hey, got a question for you. Is this normal? Or they present to an ER urgent care because the kid was fine, and then kind of fell off that cliff. So probably you guys will see this even more than I will for presentation. So that is why I want you to be aware to recognize things. What is my initial workup, and then where do I need to get this kid? That's why we're talking about it, even though it is only about 4% of the pants. So this is where we're going. So things to think about in general is that pediatric cancer in general is much more rare than other things that we have talked about. So when we talk about congenital cardiac issues, that was a 1 out of 100 babies. And there's not a whole lot of congenital cardiac out there necessarily. This now is 1 out of 300. So just to give you an idea of the prevalence that you're going to see this. The problem with that, and some of the reason, not that you want more pediatric cancers, but because it is relatively rare, and because it is not associated with a lifestyle, right? This is not like, man, that baby just really started smoking early, started hit the bottle early. Right? There's not a whole lot of lifestyle interventions that we can do. Most of them are genetic, spontaneous, and rare. And those things, genetic, spontaneous, and rare, don't get a whole lot of funding for research, development, and for treatment protocols. So functionally, even though it's kind of interfaces pediatric cancer stuff, there's not a whole lot of money or research because it is not as prevalent. So both the good and the bad of that. What I don't need you to do is spend time memorizing these charts. Again, my hope is to highlight certain things and certain things to be aware of when you are practicing. So if you're looking at your x-axis here of this chart, it is the age in years. If you're looking at your y-axis, you're looking at how many, and then you're looking along the bottom of the different types of cancer. So if you were looking and saying, I really think that there is a leukemia here, you're probably looking at a toddler. Right? Not to say that a teenager or a newborn baby couldn't have that, but if you're looking at a 2, 3, 4-year-old, your chances of leukemia are going to be higher than anything else. So it just gives you that relative prevalence rate of, if I'm thinking sarcomas, I'm thinking older teenagers. Leukemias, I'm thinking toddlers. CNS, thinking very, very young. Same for this. Or if you're having to say you don't know anything else on the test, but you see an age of the patient, what should I try to guess? If I'm thinking, again, some of these tumors we talked about, a retinoblastoma. Well, we said that was part of the newborn exam, the white reflex, so I'm going to guess baby. When we talk about leukemias, I think I remember her saying something about toddlers, so I'm going to go with a leukemia. If we talk about anything soft tissue or organ specific like that, we're thinking the older kids. So just to give you an idea, if you have nothing else to work with, the age for pediatric oncology is going to give you a significant advantage for your diagnosis. So some general principles as a reminder from your chemo class. Things that are particularly effective for pediatric cancers, so chemotherapy is going to be one of them. If you think about kids, are their heart rates lower or higher than adults? Higher, yep. So there is more circulating blood flow. So chemotherapy is particularly effective because it is a higher blood flow, a higher velocity that is going, but it also means that you have higher risk factors for metastatic disease because you have that increased flow. So When you're thinking, is this pediatric cancer going to need chemotherapy? Most of the time the answer is yes, for that reason. Some have radiation involved with them, not as much as your adult cancer, so just in general. And then your surgical resection, so certainly that will be part of the process. Lymphomas are your big limiting thing. So lymphomas, though it looks like a solid tumor, they are very sensitive to chemotherapy. So it is one that we do not do surgical resection for, we still do chemotherapy for at first. The ones that we do surgery for, as a reminder, so you can either do neoadjuvant therapy, where let's say you have a tumor that is wrapped around a blood vessel, you're going to start the chemotherapy to shrink everything, then resect it, and then continue on with the rest of your treatment, versus you will remove the bulk of the tumor and then start chemotherapy with what is left for an adjuvant therapy. So 2 different types. And then this is the part that I want you guys at the bottom. This is more for me than anyone else, but highlight it, star it, do all the things for your targeted therapies, because this is where pediatric treatment is a minefield, because a lot of these monoclonal antibodies and biologic response factors that are done with these protocols rely on the child never having systemic steroids, because that throws the protocol off. So if you really think about when we have talked together now for what, 42 hours together of Pete's lectures? How many times have I said we should do systemic steroids for something as an outpatient or as an ER? What if I said we should do systemic or oral steroids for? Remember? Asthma, okay, that's one. What's the other one? It's another respiratory croup. Yeah. So those are the 2 things that I've been like, let's do steroids for those. The rest has all been topical or something else, or an inhaled steroid. And so when we say, hey, don't just throw steroids at a kid, if you're gonna throw something at them, fine, throw amoxicillin, but don't do that, right? But what happens, and the reason we say don't just throw steroids at kids is because a lot of times, if you just throw them, you've completely negated their ability to do some of these protocols. So be very careful and cautious if you're giving a child, especially a pre-pubescent child, systemic steroids, if you in any way on your differential think that it is something to do with pediatric cancer. Okay? So that is much different than adults where you're just like, it's a day that ends in Y, throw some steroids at it. So that was for me. Tumor lysis, yes ma'am?
Sorry, just for like the targeted therapies, not like.
Correct. So a lot of the, so chemotherapy, radiation, that kind of stuff, sometimes steroids will be part of the chemo treatments. But when you're using a lot of the biologics and some of those targeted therapies, if you have been on systemic steroids before, you are not eligible for those protocols. So tumor lysis syndrome. So now we have these chemosensitive and these little bodies with a high blood flow. We are busting up the cells that have cancer, and everything that is intracellular is now going to be extracellular. So the things that were inside the cell, potassium, uric acid, phosphate, are now going to be on the outside. Now you have a big problem because you have high circulating concentrations of that. With high potassium, not going to be great for the heart, so arrhythmias, cardiac arrests. If you have a young child that has gout, it's because you have precipitated uric acid going on. So things to think about. What are you going to treat that high uric acid levels for kids? How do you treat gout? Yes, allopurinol. So this would be an instance where you would give allopurinol to a kid. How are you going to treat excessive potassium? You could give some calcium, but it's not going to bind to your potassium. Could give that, it's transient, albuterol. A potassium spray, sure. You could do that over time. Yep, you're going to use something called K-Exlate too. We'll bind to that section for you. And then for your phosphates, you can give, gosh, what is that, aluminum hydroxide? Just bind to that. So if you have this hydroxyl group out here, not the other one, that's fine. Identical. Things that we are also worried about is that now you have taken out, though you've taken out some of the cancer cells, you have also taken out their white blood cells. So any chemo is going to attack high turnover cells. So things that are high turnover, red blood cells, white blood cells, hair, skin cells, things like that. That's why you're going to see that with severe neutropenia and infections. And then other things that we're going to look at, other emergencies, would be if you think there is increased pressure in the brain, or certainly respiratory distress from a large mediastinal mass. So we'll look at a couple of examples of that. The weirdest pediatric picture ever, because he's not a pediatric patient, but a reminder to think what was intracellular that has gone extracellular, and how do I need to combat those different things. That does not precipitate and hurt a kid if they come into the emergency room, because tumor lysis syndrome, they will present to the emergency room, and that is where they will then come for that very emergent treatment. If you have an infection in these kids, so that's the other thing that we would think about. So maybe we're not doing the protocol for this kiddo that has cancer, but they are now immunocompromised and they have found themselves in your clinic. The parent has brought them to the true clinic where they are in some sort of emergency setting. So it's kind of a double whammy. So if you think about this, anytime you have a patient that has any type of cancer, you have a patient whose body is being attacked by aberrant cells and is taking out the exact fighters that can help that. So the weakened immune system plus being attacked. Now you have this in a child who's trying to be a transformer and grow. That's a really rough combination, and that child's going to have trouble growing. That child is going to be incredibly fatigued, and that child is going to have such a low threshold to become septic and kind of take on you for this. So certainly going to get more frequent infections, and they're going to be big, bad, ugly infections and very unusual infections. So if you start seeing things on a test that you're just like, I haven't seen that bug in a long time, it's probably because they're trying to tell you there's something underlying going on. Things to think about where those infections are going to arise from, just using your provider brain. If we put a line or a tube into somebody that is not native to them, the risk for infection is going to be huge. So pick a tube or line from a urinary catheter to a PICC line to a port. Pick one of those, it's going to be a high infection risk for that child. A lot of times their fever is their only presenting symptoms. They might not have anything else besides this fever. And the way that I think about that in kids, particularly kids that do have an oncologic diagnosis, and kids that have cancer, is that their entire immune system has made one last stand. They're down at the Alamo, and they're trying, it's like one little flag that they're trying to wave to say I'm septic before they kind of drop. So this fever is often the only symptoms. You're like, well, I would expect them to be really sick with all these other things. You're like, no, we've got one little flag in the Alamo. Right? So if you're thinking functionally about that. And that is why a child that is immunosuppressed, has neutropenia, plus a fever, if they have mounted a fever in the setting of neutropenia, that is a medical emergency. And that is do not pass go, send them to the hospital. They need a blood culture, they need IV antibiotics, they need admission, you need to watch them like a hawk because they are very, very, very sick. Okay, so big takeaway from that is this would be the time where fever is a huge, big, bad presenting sign. If they have neutropenia in the setting of a fever, medical emergency. So broad spectrum antibiotics, start them on something, get a blood culture. So now we get into some of the specifics. So the different types of leukemia. So the most common type of childhood cancer is going to be your leukemia, which just gives you an idea. Prevalence again, it's the same as always. I'm not going to ask you how many numbers and what percentage of malignancies. It's a waste of a test question, but it just gives you an idea of what the prevalence is, which you're the most likely to see of these unlikely cancers. Remember, the high risk populations are those ones that have an underlying genetic component to this. So when we talked about Down syndrome from block 1, where they have 3 versions of 21, right? Trisomy 21. So if they have 3 precursors, they're more likely to make those precursor cells that are going to become aberrant. So part of that annual workup for a child with Down syndrome was an annual CBC for this reason. The other one that we talked about was neurofibromatosis. So a lot of your neurocutaneous diseases, tuberous sclerosis, neurofibromatosis, they all have this increased genetic tendency to produce cancer cells and tumor cells. So leukemia is one of those that we often will see. Reminder, you can have a LL, lymphocytic line, and this is the classic one when we think about this. So it's rare, so pediatric cancer is rare. The most of the rare is leukemia. The most of that is going to be ALL. So if you had to guess something, if you have to guess on a test, the most common is going to then be ALL. So you see this in your toddlers, male toddlers, and that's typically the way that it is going to present in something. So you're like, ooh, that's not normal, male toddler. Could be a female toddler as well, but you just, prevalence-wise, that's what you see. Your AMLs, so those ones, you see really a bimodal distribution, so very, very young. So neonates, like true, like out the womb, I have cancer. Neonates, and then adolescents, so the flanking sides of pediatrics in general. And then your chronic ones are a little bit less common as well. And we'll talk about some rare versions in just a second. Most of these are pretty responsive to chemotherapy, and the rates of how kids do with this, it went from a death sentence to incredible survival rates. So pediatric leukemia has come a long way. So what are they going to look like? They're going to show up to the ER, they're going to show up to your clinic, they're going to show up somewhere. What are you looking for? So that fever, last stand, so that could be one of the things that they're presenting with. If you think about pallor, so what is going on with this? So one of the lines of the cells in their bone marrow is crowding out the rest of their bone marrow. So all the other cell lines then are downregulated because they're like, well, I'll just get out of the way and let whatever happen. And so if you have then a decrease in those red blood cells because that bone marrow is not making them, they will present with significant pallor. So that'll be one of the things to see. If their body is fighting off this incredible amount of aberrant cells and working harder, because that tumor is requiring so much of this energy that is usually going to the kid playing, living, and growing, you're going to come in with severe lethargy. So this would be an example truly where the parents are saying, my child is lethargic, and you go in and the child is lethargic, true lethargy. And then bone and joint pain, right? This is very painful in the bone marrow. So most of the time, you don't ever see a kid presenting for chronic pain. So if they're saying they've had this persistent pain somewhere for more than about 10 days, that should make your provider brain light up. That's not normal. Kids will be like, my elbow hurts, and then run off, right? So persistent pain in the same spot should make you think something else is going on that I don't typically see. We're looking for, on exam then, your lymphadenopathy in any place where you have lymph nodes, that they're going to light up kind of everywhere. We'll talk about specific ones that have specific places that you need to look. If you're having hepatosplenomegaly, so is your body trying to pull out those abnormal cells or filter abnormal things. And then certainly if you do not have those red blood cell lines or your platelet lines, bruising and bleeding. So the classic, I have fever, weight loss, bruising, bleeding. That is why we're talking about those things. For leukemia, the problem sometimes is that you catch it on an upswing, so sometimes your CBC is not helpful. The classic one is that you get this CBC and you have one cell line that has overshadowed all the other cell lines. So you have white blood cells that are 50,000 or more, and you have functionally hardly any red blood cells, or functionally hardly any of the platelets. So that's kind of the classic definition. And when you see this on your smear, so if you've gotten something, your CBC is not looking pretty, right? You have 50,000 on one cell line and nothing in the other. You say, I want someone to look at this under a slide. So you're going to get a peripheral smear, and I want somebody's eyeballs to take a look at this, and they report you have blast cells. Blast cells, you should be like, I need to stop clinic. I need to walk down to the lab because I want to see this for myself, because a blast cell, this baby cell that's been pushed out, it says I'm immature and not functional, and I am cancer until proven otherwise. So if you ever see a report of a blast cell, blast yourself out of clinic or blast yourself out of the ER and go take a look at that, because again, pediatric cancer until proven otherwise. This thing will not be for you, but things to think about. They will end up doing a bone marrow aspirate to see what is going on in the marrow. And then for staging purposes, You'll always do a lumbar puncture for these kids to say, well, how far is the metastasis gone? So there are some times where they will ask you to do it in the ER if you are already doing a workup for other things, or if a child truly comes in lethargic and you're thinking meningitis is on my differential. Doing this LP, a lot of times making sure, hey, Hemong, if I'm getting this LP anyway, what other things do you want? So, can be something that always happens, but that is for staging purposes. When you are doing your differentials, I just said meningitis, so that could be something that is on that differential, but the true lethargy that they're coming in with. Pick an infection, any infection, that's going to be also on your differential. So, truly, any infection. Look at that because you have fever, malaise, anorexia with that. Your other malignancies are on your differential, so we'll talk about all of these in some detail. Aplastic anemia, so that could happen in the setting of thinking about what disease, what infection that we talked about goes after your red blood cell progenitors? Parvo, yep, exactly. So you could have this aplastic crisis. Or you could end up with, we call it rheumatology things, right? So you could have a presentation of a rheumatologic condition, a JRA, a JIA, or something of that, or ITP. So if you're looking, hey, we don't have any platelets, but it's just the platelet line, that could be under differential as well. The special case that I talked about was particularly with those kiddos with Down syndrome. So this is just more something to make sure that you are aware of, because these kids come in for care a lot, and so this case does come up often. I see it tested because leukemia is pretty standard and run-of-the-mill. So if you have a child that has T21, you again already know they have the 3 precursors, and so you're more at risk for this. I'm already getting an annual CBC to pick up on some of these things, and so that year I get the CBC and I say, oh my goodness, I have WBCs. I see blast cells, I've blasted myself out of the clinic, and I'm going to go down to the lab to look at this. Yes, peripheral smear, this looks like a leukemia. You're already at risk for that. You send them to hematology, and Hemonc then does a bone marrow aspirate and says, no, the marrow's fine. And you're thinking, okay, then what's going on? Well, they have this transient myeloproliferative disorder where it ends up, the marrow fine, periphery is not fine. And then you have decision point 2, again, in the Hemonc world, to say they're probably going to be fine, but a third of them are not going to be fine. So this is one that you're watching really, really quickly, or really, really carefully and closely, and doing quarterly then follow-up for CBCs, because you're going to see, are you in that third of kids that are already at high risk for leukemia, that have this condition that I'm afraid is going to morph into a true leukemia. So just to be aware, if you're doing increased surveillance on these kids, they do well until they don't do well. So something to be aware of for them. And ultimately, for all of these kids, you're referring them to PEDS Hemonc, and Hemonc will do the definitive diagnosing of bone marrow biopsies, flow cytometry, to get you your genetic diagnosis for this and come up with your treatment plans. So your job as the primary care PA, and the things to know, can I identify the child that's at high risk? Can I do that initial laboratory workup? And do I know what to look for with blast cells, with cell lines that are down, with do I need to get a lumbar puncture or not? Do I need to avoid steroids in this kid? And then how do I get them to PEDS Hemonc? That is the role that the PA is going to play in this for leukemias. Okay. For lymphomas, our lymphoma cases, so those are the ones we talked about. These are solid tumors, and they are treated a little bit differently. So yes, it's common. You can see this in younger kids, but classically, again, if you had to guess on a cancer for a teenager, this would be what you were going to come in with. And the way I've seen this classically tested is that you have a teenager that comes in respiratory distress from something, from sports or something, and you're like, I know what this is asthma, I've got it. And then all of a sudden you're like, they're not giving me any other asthma things. I don't know what this is. And they're trying to tell you that there's a mediastinal mass that is causing acute compression. So they were able to compensate until it became so large that they could no longer compensate for that. So this is a teenage presentation. Some evidence will suggest that there was a 2-hit hypothesis, that they got hit with an Epstein-Barr virus, and that was hit, where they had an underlying genetic cause, so that was hit one, then the Epstein-Barr virus kind of knocks that, and now the genetics of it start, so kind of a role for that. When you're thinking about types, you have Hodgkin's, non-Hodgkin's, so you get a case where you actually want the named disease. So Hodgkin's has a much better outcome and prognosis in teenagers than your non-Hodgkin's. So a little bit older ones that you see there, take a look at some of that. So non-Hodgkin's again, much more malignant, much more less differentiated, so the cells are much more immature, harder to specifically target them, so they just have a poorer prognosis. The two different types, you can have it's either sporadic form or then your underlying endemic form. And then your presentation. So while I said most of the time I'm thinking of this in the chest and that mediastinal mass can present different places and can present as your tumor lysis syndrome. If it grows large enough, all of a sudden your body is starting to lyse it. This can be the presenting symptom. So it can be a little bit scary for that. When you're looking at your history of this, your history of your B symptoms. Did they go over B symptoms in hematology? You heard that? So for the longest time, and I'll tell you, I was so dumb. I had no idea what B symptoms were. I was like trying to make it into like something really scientific. I was like, oh, they must be from the B lymphocytes that are the type of some cell, and like this, I don't know. All it was Ann Arbor came up with a staging system, 1, 2, 3, 4 for metastatic disease, and then do they have systemic symptoms? That's A. Do they not have systemic symptoms? That's A. Do they have systemic symptoms? That's B. So B symptoms are just the Ann Arbor staging. I was just like, oh, well, I'm dumb. Like I thought that it was some like specific type of cell. It's not. So your B symptoms just mean is their body having these systemic symptoms. So systemically, have I said I am mounting a fever and I'm trying to do this? I'm losing weight. I am up with night sweats and chills. So that is the systemic symptom that just puts you in that classification of having, yes, they do have systemic symptoms or B symptoms, but that's how you'll hear it for the rest of your career. Do they have any B symptoms? No one even knows what that means. Anyway, but for these lymphomas, they again will come in some sort of respiratory distress with the rest of those B symptoms because of the massive amount of compression. And this would be one of those places that you're looking for lymphadenopathy, but your specific place that you're looking is supraclavicular. So if you ever on top of a kid, so if I'm looking at an exam and I'm feeling the neck and I'm going down to the neck, I will always run my hand along the clavicle, because if you feel a supraclavicular node, that is abnormal until otherwise proven. So that is just part of my pediatric exam that you do, is checking for that supraclavicular node. It is lymphoma until proven otherwise. The reason that you're going to rely on that, we'll finish this and then we'll take a break, is that your CBC is probably going to be normal. It's a solid mass. So you need to, in this case, trust your physical exam skills. If you are getting an imaging, your chest x-ray will show this giant mass. And then your CT is then going to be for your staging. Your bone marrow biopsy, again, for oncology, they're going to be doing that. And they will do any kind of peripheral tissue biopsies as well. If you have that, you'll see those Reed-Sternberg cells. So let's take a break though. I want to cut into our break time. So come back to Sternberg cells. So those cells that look like they have googly eyes on the inside. Those are the way that you will see that. That is one of the board exam's favorite ways to just show you a picture to see if you remember what that is. So again, so this is an interesting x-ray of what you will see with a teenager with lymphoma. So when they always talk about the widened mediastinal mass, you see that the mass looks like the same size as the heart, so this giant wide mediastinum. But what is the black little arrows pointing at? Yes, the black tiny, the arrows are looking at the trachea. So you're seeing that the trachea is incredibly compressed. It is not only shifted, but it is teeny tiny, it is tortuous, it is compressed. So that would be very, very abnormal. So again, why they are coming in this respiratory distress. This mass has reached a critical mass, to now where it is compromising the airway. So that picture, or the picture of Reed-Sternberg cells, look like little Hodgkin the owl. Those are all indications of, again, lymphoma. And they're probably trying to ask a question, either what is the diagnosis, or what are you worried about, in which case it is tumor lysis syndrome, which is what you're going for. So things to be aware of, the ways that they could ask different test questions, or the ways I could ask different test questions. Again, it's sensitive to chemotherapy, so this is often one of the ones that will be, even though it's a solid mass, you will use chemo and radiation rather than surgical resection for this. Again, non-Hodgkin's is much more aggressive, so if you had to pick one, you would want the named disease, the Hodgkin's lymphoma, even though overall prognosis for either one for these kiddos is really pretty good. Which takes us to CNS tumors. So these ones are sad, and again, the collective amount of this. So when you look at, pediatric cancer, rare. Most common of pediatric cancers, leukemia. Most common of the pediatric cancers that are rare, ALL. However, when you look at all of them combined, the most common malignancy is some sort of CNS mass in the kid. However, individually, the different types of masses are all very, very rare. So a little confusing for that. But the reason that we harp on this, even though individually they are rare, is most of your mortality comes from this. So if you're looking, oh, ALL has this great survival rate. Oh, lymphoma has awesome survival rates. Your CNS, 1 out of 3, don't do very well. So mortality for peds CNS tumors, not great. Again, those same things, those neurocutaneous disorders, so a couple that we already talked about from our neuro lecture, neurofibromatosis and tuberous sclerosis. Those two are ones that you should be aware of, because again, not only with leukemias can you see that increased risk, but you see this increased risk for CNS tumors as well, because they have that neuro component of the neurocutaneous disorder. Please don't memorize percentages. Something to be aware of. When we talked in the neuro lecture of what kind of imaging do you need to get for kids, why did we say that you needed to get MRIs versus CT scans for kids? High radiation, but what do you not see well on a CT scan in the trial cell? Okay, and what part of the brain can you not see very well on a CT scan? Yep, in that posterior fossa. Yep, so you don't see well this posterior fossa where you see the majority of brain tumors in children. So yes, you are going to see some gliomas, you'll see some craniopharyngiomas, you'll see some of the other stuff, but the bulk of these tumors are going to be in that posterior fossa, and you don't see that well on CT at all. So that is, again, if you're like, if something doesn't feel right, look right to you as a provider, where you're like, that's a focal side, that's not normal for a kid, and the CT scan is still normal, get that MRI in that posterior fossa. Because the most common two types of tumors, your astrocytoma and your medulloblastoma, are both in the posterior fossa. So now you have an instance where you're like, well shoot, the most common type of cancers that are going to be the most prevalent are all in those places that I don't have a very good picture of. So your astrocytoma is the most common, pretty good prognosis, and then your medulloblastomas in the cerebellar area, variable prognosis. The earlier the diagnosis, as with anything, a better outcome is going to be. So again, making sure that you as the primary care PA have the right imaging modality and you don't just send somebody home with a clear CT scan who has symptoms in front of you that are super concerning. And then, so what is that? When we're talking about those focal findings, where on exam you're like, oh, something's not right. Probably the most common way that I have seen this is ataxia in a kid. So yes, you can have numbness, tingling, you can have decreased strength, but really when these kids start walking funny. And so when kids are learning to walk, you watch them waddle, you watch them fall down. These kids, it's like they go in reverse. And so all of a sudden now you have a 3, 4, 5, 6, however year old who's stumbling around, feels like the room is spinning, they can't get their balance. It is ataxic gait. That should make you very, very concerned that something in that posterior fossa is going on. Can't say this enough. MRI is going to give you that imaging that you need, especially in the posterior parts. Your adjunct studies then are going to determine what all the other things you get. This would be the case that if you are thinking this child is truly lethargic, that they don't have a fever, they don't have purpura, they don't have something else, but do I need to get a lumbar puncture? Scan first, because this is the kid that doesn't have that open fontanelle, doesn't have that pop-off valve, so they really are at that high herniation risk. So scan before you do any kind of LP is going to be necessary for this. And this one is not just oncology, because a lot of times these are not radiation and chemo, they need neurosurgery as well to debulk that tumor. Okay, this gets messed up every semester, so you have to pay attention, summon that up with your Herculean strength. Okay, this would be the time. So, neuroblastomas versus nephroblastomas. Very similar sounding words, two very different systems. Okay, so neuroblastoma is the neurologic system. We're talking about that. It is some sort of neurologic and embryonic origin tumor that is outside your CNS. So functionally what that means is when you are in embryology, you have these neural crest cells. And the neural crest, they all are together and they're like, hey, on three, ready? 1, 2, 3, break. And they go around the body and they make different parts of that neurosystem. Right? So an example of that is your adrenal glands. Part of your neurologic system, even though they are outside of your classic CNS. So anything that is derived from your neural crest cells is part of that neurologic system and can result in a neuroblastoma. So most common childhood malignancy, CNS malignancy that is outside the CNS. So where does this typically look like and how does this typically present? It looks like a child with an abdominal mass who cannot verbalize this to you. So they come into a clinic for an 18-month well visit, a 2-year-old well visit, they're not particularly verbal at that time. You mash on their bellies and you're like, oh, well that's a hard belly, right? What should a child's belly feel like? Should feel like sourdough bread, right? They're just these big old toad bellies that are super soft. So if you all of a sudden you're like, that's not sourdough. Sourdough craze. I do not make sourdough. This big hard belly, then you start thinking, do I have a neuroblastoma going on? It can occur anywhere in that sympathetic system as those neural crest cells, but it's most often going to hit your adrenal glands or some of your other spinal ganglia. So something in that posterior, but often in the abdominal region. So again, abdominal mass can have pain or not. They start having your systemic symptoms of fever and your weight loss. And really the weight loss is crowding everything out and it is turned on your sympathetic system. So when you look at that paraneoplastic syndrome, it's basically like somebody turned on your sympathetics and does not allow them to turn off. So it's profuse sweating, or secretory diarrhea, and then your eyes that are dancing. So that's what opsoclonus myoclonus, dancing eyes, where everything is kind of turned on and on this go mode. So that is typically what you're going to see. If you have pain in these kids, again, a lot of times they're non-verbal or they're not significantly verbal yet. A lot of crying, particularly holding a place somewhere, and that is oftentimes from a metastatic process. So a painful abdominal mass or any kind of abdominal mass in a toddler, one of the things you're thinking is neuroblastomas. Now, because this is from those neural cells, if you get your catecholamines from that sympathetic system, they are usually through the roof. So that is one of the things that you can get because you know that embryologic origin. So if you are getting that as a primary care PA, your urine catecholamines can be helpful to say, ooh, this is really actually something going on with these neural crest cells. Certainly an abdominal image is going to show some calcifications that should not be there normally. And then you're going to basically scan them from neck to pelvis. So CT or an MRI of not only your chest, your abdomen, and your pelvis, because again, it can be anywhere along that chain. So you're functionally going to see everything along there. You can see this in developing neonates too. So sometimes you will see this on a prenatal ultrasound. Those ones actually do better. So the younger you are with this, the better you do. Oncology is going to do this again. You're going to take a biopsy to make sure that they have the correct diagnosis. You're going to
staged correctly with bone marrow aspirates. And then again, depending on the age of the child, their outcomes are going to matter with this. So this is one, and it's counterintuitive, but the older you are at the time of diagnosis, the worse this is. So it's really sad at diagnosis when you have a baby that has this. However, their prognostic indicators are so much better. So by the time you're talking, if you're able to talk and you have this, not a great outcome. Okay, so that was neuroblastoma. It is different than a nephroblastoma. Somebody messes this up every semester. I'm just telling you now, different words, neuro and nephro. Somebody who's not listening right now, I swear to you, you're gonna get this mixed up and I'm gonna not be happy with you. But the other name for a nephroblastoma is a Wilms tumor. Right? So those should be AKA synonymous with each other. The thing about this is it's also an abdominal mass, and it is on the renal system. So adrenal has the word renal in it, but it does not mean renal. And renal is not the same as adrenal. I say this because every semester somebody gets it mixed up. So your renal tumor arises with this nephroblastoma, an abdominal mass that you see arising from true kidney origin. So not any neurologic, not any neural crest, true kidney embryologic tissue. And typically, if you have a Wilms tumor, you have something else going on. So the neuroblastoma had a normal child with nothing else going on. The nephroblastoma typically has something else. Not always, but most of the time and for testing purposes, something else is going on. So Wager syndrome, which is the worst acronym in all of peds, but it was a Wilms tumor, so they didn't even name it properly, they should have called it the nephroblastoma. But Wilms tumor is the first name, and iridia, we'll take a look at that, so there's no iris. Some sort of GU malformation, so it could be anything GU malformation, and then a range of developmental disorders, like this is the worst acronym ever. But the point is that you are seeing other manifestations along with this tumor. You see this in other syndromes as well. So there's a syndrome called Beckwith-Wiedemann syndrome. It's super interesting. It's called a hemihypertrophy. So one side of the body grows and the other side does not. And so you end up with like a Popeye arm or a Popeye leg, and the other side that is a lot smaller. But you can see that a tumor can grow on that hemihypertrophy side, and often that tumor is associated with a hepatoblastoma or a nephroblastoma. So Wilms tumor associated with some syndromes as well. Same young age in these kids, and it can again be one side or both sides. So the presentation is often very similar. You have a young child, a 2-year-old child is the classic presentation. 2-year-old child with an abdominal mass, and you are trying to decide, is this an adrenal tumor or a renal tumor? Nephro and neuroblastomas. This is that worst acronym ever, but the Wilms tumor, the nephroblastoma, no iris, GU, range of developmental disorders. This abdominal mass, a little bit different. The other one often had pain associated with it. This one is often painless. That would be different one. It's not always necessarily that way, but if you had to guess, this one is going to be an asymptomatic painless mass. However, this one, because your renal is involved, you're going to have hypertension. So in a 2-year-old, remember we were like, we don't even get blood pressures in standard kids until they're 3. If you have an abdominal mass then on exam, this would be that kid that I'm thinking, I'm going to go ahead and get a blood pressure, even though it's not standard, because now I have an exam that is pointing me to something, and I'm trying to see if it's nephro or neuro, and that blood pressure can help me differentiate that. So I'm going to go ahead and get this blood pressure on this 2-year-old. So hypertension can be one thing, and then the hematuria, again, you're bleeding because you have kidney involved here. Your CBC, because any pediatric cancer, you're going to see is there metastatic bone marrow involvement. So you're looking at the periphery. Your UA, again, for painless hematuria, and then your renal function studies. Is the kidney being involved? Is the kidney getting hit? And then liver, because Beckwith-Wiedemann will also have a hepatoblastoma, so a little beyond the scope here, but something that you will also get on your CMP, and that is the reason behind it. Your imaging is going to be the same. You're looking kind of from neck to pelvis. for your chest, abdomen, pelvis, and then your chest x-ray. So when in doubt, for a child with any type of cancer, go ahead and get a chest x-ray to look for any kind of chest mets or chest mass. Oncology, again, we'll do a biopsy of the tumor, surgery to debulk that tumor, make sure that they know what the stage is to be able to determine what type of chemotherapy or radiation they are going to do. And this one has a pretty good prognosis. So if you had to pick between a neuroblastoma and a nephroblastoma, you want the nephroblastoma. However, you often have the syndromes that go with this. So, and again, depending on your age and stage, I can have a more or favorable diagnosis. So, and your big job is to make sure in this setting as the PA is to say, can I do a good exam? Do I know what a baby belly is supposed to feel like? That's a hard mass. I need to get a blood pressure to help differentiate that, and some of those general labs, get them to pediatric hematology and oncology. That is your role in this for the purposes of PEDS onc for that. Okay, so those were those little kid tumors. So the little kid stuff going on, and then we get into our sarcomas. So sarcoma, you're thinking about what is this tissue? This is connective tissue. So any kind of connective tissue. So this is vessels, this could be in muscle, this could be in bones, this could be in any kinds of things. So any of these musculoskeletal systems, fat, fibrotic tissue, anything. So sarcoma is a wide range of things. So we're going to look at a few of the particular types. So the thing to look on here, again, recognizing what the symptoms are like, and then being able to differentiate between the substances that these tumors present with. So your most common is going to be your rhabdomyosarcoma, your muscular in the muscles, and then your two bony tumors, your osteosarcoma, your Ewing sarcoma. So we'll look at those in some depth. Again, those same ones, those neurocutaneous disorders, have the same hereditary pattern to it. And one thing that I want to make you aware of, because I hit it so hard with the white reflex, with retinoblastoma, going to ophthalmology, is that even if you catch those, you caught the right white reflex, you're like, I know that's not normal, I got them to ophthalmology, we got the retinoblastoma identified, we're doing great. Those kids, because they have had radiation therapy as a young child, end up at risk for a secondary osteosarcoma. Okay? So those can be some of the most devastating ones because they survived the one type and now they have a complete second type of cancer. So something to be aware of if you see that in a medical history at any point. So if you have this rhabdomyosarcoma, so some sort of, you're older, so you're typically a school age or teenager, and now you have a skeletal muscle that is involved, that tumor is going to make a small round blue cell tumor. So those are those kind of catchphrase key words to think about, but when you're looking at it under a slide, the pathologist is looking at small round blue cells. Right? So this is when you realize that medicine was not as sophisticated as we could have been. We're like, what do I see? Small round blue cells? I'll call it small round blue cell tumors. When you're thinking about where is this going to be, we talked about skeletal muscle tissue. Most of the time it's hollow visceral organs. So you're looking at the GU, the bladder. You're looking at the orbit, a hollow visceral organ, places that you see this typically for these things. Versus an osteosarcoma, so the two types of bone tumors. And these ones present a little later. So this is ones that the ways that I have seen an osteosarcoma and next a Ewing sarcoma present have always been the same, at least for me. And it has been somebody who gets to basic training, it's a 17 or 18-year-old kid, and has persistent pain with PT. And that is how they have presented every single time. And so somebody says, oh, you just haven't worked out, oh, you just need some Motrin, oh, go see PT, and they end up with these bony tumors. And they are under the pediatric protocol, so then they come out with us. But that was the presentation I saw of this over and over and over. So something to be aware of if you are out in this true clinic with these really young, still teenage patients, if they are coming to you with persistent pain at a persistent site, please scan that at some point because they are at risk for these bony tumors. So if you have an osteosarcoma, long bone tumor that you typically see at the distal end of a bone, so distal femur, proximal tibia, proximal humerus. And they will come in, a lot of times attribute it to some sort of trauma. Oh, I was playing baseball, I was playing soccer, I was playing something, I had this traumatic event, and now the pain has persisted. And again, you go with those kids also that had a retinoblastoma. And this type of tumor does not make a small round blue cell tumor, it makes an osteoid substance. So that should make sense, bone with bone. Osteosarcoma makes an osteoid substance. If you decide to get a scan of this, so this person has come in, this teenager has come in over and over and you said, let's just take a scan of this. What you're going to see is a starburst pattern. I don't understand what that actually means because to me, it looks like a head of cauliflower. So if you're looking at this, if it looks like a head of cauliflower or broccoli, I'm like, but the radiologist will say starburst pattern. And I'm like, cauliflower, starburst, should not look the same, but that is me. But you can see these pronounced joint involvement, right? So this is pretty significant, this is pretty advanced. Please tell me that if you were the PA who saw this on a shoulder, you would be able to say, those two things don't look alike, right? You want to catch this way before they get to this point. But that pattern of a head of cauliflower function, the starburst pattern is what you're looking for on exam. Contrast this to a Ewing sarcoma. So this one is also in the bone, a bony tumor, but you're looking, and this one has oftentimes earlier pain and more systemic symptoms with a fever. And often you'll think that this is more infectious in its etiology, but it is a tumor type. The difficult with a Ewing's sarcoma is that it is often a very deep tumor, so you see this in the pelvis, and that's always where I've seen it, is that this presents very, very deep in the head of the femur or deep into the pelvis, so it can be a late presentation of this. And this one is interesting, and the reason that it always gets brought up is because under a slide, under pathology, it also has a small round blue cell tumor. So then you're like, well shoot, is this a rhabdomyosarcoma or is this a Ewing's? Okay? They're both going to look very similar under a scope. So differentiating with your scans, with your genetics, and with your good physical exam and history is going to be of utmost importance. On scan then, it doesn't have that cauliflower starburst pattern, it has an onion skin pattern. So more than an onion skin, I always think like what was that, like Applebee's that had like the awesome blossom, where it just kind of had the, was it Outback? Yeah, just one of those that had that onion thing. But it just peels away in layers, so it just kind of has like a wispy look that looks like you could just kind of peel away a layer at a time, is really what this onion skin or this moth-eaten appearance is at the edges of the long bones. In all of these, you're going to, again, make sure they go to oncology, and they're looking at, again, small round blue cell for rhabdo and Ewing's, or that osteoid substance for osteosarcoma. Some of them will have specific genetics, so Ewing's is an example of that, where you have a translocation on chromosome 11 and 22. So that translocation has been a genetic cause of this. They will determine, that determines your therapy, so can you do targeted therapy or not if you have this particular genetic entity. What I don't need you to do is memorize the particulars. The idea of this is to say that each of them, even though they are all sarcomas, depending on this place, the treatments are going to be very different. Some of them have a surgical resection. Some of them have chemo first, then followed by a resection. Some of them have radiation therapy, some do not. So a big takeaway is that eventually they will have chemo, radiation, surgery, different orders, different amounts. Your job is to get that workup and get them to the appropriate place. If they have METs, it's going to be a worse prognosis, as with any cancer. And then the degree of tumor necrosis is a positive indicator. Meaning if they have responded and that tumor is dying, that is a prognostic good indicator that they are responsive to the therapies. Okay, so in general, when you are assessing this patient, please listen to them. If a parent comes back in and they say something like, we've been to our dumb pediatrician 3 times, that doesn't happen, but I'm just saying, if they say, we keep going, no one's listening to us, this pain is persistent, this kid has persistently said, this area hurts for weeks, listen to that that family because, again, kids don't often present with pain. A lot of times they're non-specific, those B symptoms are systemic fever, weight loss, chills. And remember, kids should never be losing weight, they should be growing. So any weight loss in a child is concerning. And then always thinking about that compressive factor. If the child gets to the point where they have a mass so large that they are having symptoms like ataxia, compression, respiratory distress, you know that it is significant because they compensate really well until they don't. When you are studying for these, I put a couple of these in, so just an idea of if they, this is probably more for phase 2, but it can be helpful for this, of what type of symptoms are they going to present with, and what types of tumor then, if you see that in a test question, is it going to be associated with. Okay, so when you're really talking about, okay, give me the bottom line, I don't ever want to see a child, I really don't like children, I'm suffering for your class because they make me. When you have that and at the bottom line you're like, give me the bluff, what am I looking for? Okay, what you're looking for in a kid. If they have prolonged lymphadenopathy, what does prolonged mean, Dr. Klein? It means more than 4 weeks of that same lymph node. So if you have a lymph node that is persistently large, when I say persistently large, more than 2 centimeters for more than 1 month, that's not normal. You need to check that out, get an ultrasound, get some labs, something. More than 4 weeks, more than 2 centimeters. That's thing 1. A prolonged limp. So they come in and the kids don't limp. I mean, they limp all the time and they come and want sympathy, but they don't have this prolonged limp. They don't remember that that well. So prolonged limp, especially if they don't have any reason for that, should cause a workup. That persistent headache, that was one of your red flag symptoms for the neuro section. So if they wake, if they're awoken from sleep due to the pain, worse in the morning, that should make you think that, and then any of those B symptoms, so persistent fevers that you can't explain, any kind of weight loss, those would be the things. These are the things to know as a primary care PA. Don't miss this. Don't send somebody with one of these away without a proper workup. You're probably going to miss something big, bad, scary, and potentially delay treatment for this kid, and you've opened yourself up to legal liability. So for those 3 reasons, if nothing else, that's your big clinical takeaway. Your exam then, again, your blood pressure is going to tell you a lot of these different types of tumors. So your exam and your blood pressure is of utmost importance, as is your general impression. Kids should look like they have life in them. They should look like they're just rosy cheeks ready to go and play. If they look cachectic, lethargic, just not a normal child. Any big, giant organ, you should not be able to feel specific organs on most kids. If you can feel the liver, it's probably big. If you can feel the spleen, it's probably big. If you can feel giant lymph nodes, they're probably big. Anything that has significant bruising, bleeding, petechiae, purpura, not normal. And then this persistent headache. So that's what you see with those posterior fossa tumors. These at the back, this is not, again, all-inclusive, but it puts a few review questions. So if you feel like you can answer these type of questions for this lecture, that is going to be what you will think. Since we're trying to catch up time, let's actually start endo today.